Welcome to the UNC Health and Human Rights Lecture. Established 10 years ago, this lecture series at the University of North Carolina at Chapel Hill seeks to advance human rights principles that frame public health practice. In considering human rights under international law as a basis for public health, our speakers have sought to shift the analysis of health debates from pleas of charity to accountability under law, elevating human rights from principle to practice, and transforming international law into national policy and the lives of people throughout the world. Good afternoon. My name is Benjamin Meyer. I'm a professor of global health policy at the University of North Carolina at Chapel Hill, and the chair of the selection committee for this groundbreaking UNC lecture series. I'm delighted to welcome you to our 9th annual UNC Health and Human Rights Lecture, welcoming guests from around the world to this special online lecture. Our interdisciplinary lecture series on health and human rights brings global leaders in the application of human rights to public health to speak with our faculty and students in Chapel Hill. In these uncertain times, during an unprecedented pandemic response, this lecture has served as an expression of UNC's continuing commitment to human rights advancement for public health promotion. With sponsorship from UNC's Department of Public Policy, Center for Bioethics, and Gilling School of Global Public Health, it's been an honor to work with our UNC Health and Human Rights Lecture Committee to make this extraordinary interdisciplinary event happen every year. I'm inspired to see so many of you here online, and I hope that this will be an engaging conversation for you, both during our lecture and across social media. I'm so very excited for this year's lecture on the impact of COVID-19 on sexual and reproductive health and rights, allowing us to speak with a human rights advocate, global health leader, and an inspiration to faculty and students throughout the world. It has been an honor to work with the inimitable Dr. Tlaleng Mofokeng over the course of her groundbreaking mandate as UN Special Rapporteur on the right to health. And I'm delighted to introduce you to her today. Dr. T has long advocated for health and human rights through her work as a physician in South Africa, advancing adolescent sexual and reproductive health, and leading to her best-selling book, Dr. T, A Guide to Sexual Health and Pleasure. Appointed by the President of South Africa to the Commission on Gender Equality, her work has come to promote human rights in health policy, advancing health equity in South Africa, and advancing health-related human rights through the United Nations. Last July, the United Nations Human Rights Council appointed Dr. T as the UN Special Rapporteur on the right of everyone to the enjoyment of the highest attainable standard of physical and mental health, where the UN has worked over the past 70 years to elaborate the scope and the content of the right to health. This Special Rapporteur mandate on the right to health, first established in 2002, has provided a foundation to examine efforts to implement the right to health through healthcare services, health promotion, and underlying determinants of health. As Dr. T begins her work as the 4th UN Special Rapporteur on the right to health, she has outlined sexual and reproductive health as one of her strategic priorities. And her first report to the General Assembly this year examined challenges and opportunities to advance sexual and reproductive health during the COVID-19 pandemic. Turning it over to Dr. T in a moment, I hope that you can begin by speaking briefly about your work leading up to your UN mandate, sharing with our students how your work as a young physician and an advocate framed your understanding of the right to health, and then discuss the imperative in these pandemic times to confront threats to sexual and reproductive health. Following your opening remarks, I look forward to joining Caitlin Williams, one of our amazing doctoral students at UNC, and a rising scholar on sexual and reproductive health and rights, in speaking with you about the themes in your report and the actions that students and faculty can take to support your mandate in the fight for human rights and global health. Thank you to those who are joining us at UNC and around the world. If you have any questions for Dr. T, you can submit them as noted in the chat through our Q&A box at the bottom of your screen. And we'll draw from them in these crucial conversations at this critical time. Thank you, Dr. T, for joining our Health and Human Rights Lecture Series. I turn the conversation over to you for your opening remarks. Thank you so much.
Thank you so much, Ben and Caitlin, and of course to the UNC family at large for this invitation. And I am equally privileged to have had this working relationship both with you, Ben, and Caitlin in different capacities and different work streams. And this evening, well, it's evening my time in Johannesburg, is one that could possibly experience a blackout. So if you see me freeze or fall off the call, I will come back using a different gadget, just as a disclaimer, because we work in this virtual environment where anything can happen. But other than that, really just so excited to share my journey, my experience, and of course, get in depth in terms of the report that I've just presented to the General Assembly. And as Ben noted earlier, that I am a physician working in Johannesburg. I'm a general practitioner with a focus on sexual and reproductive health. And this was not a natural progression of a career for me. And it started really when I was in medical school myself. At the time, if some of you remember or you've read the history of South Africa, we were really unsuccessful politically in terms of dealing with the HIV crisis that the country was experiencing at the time. And my time at medical school as a late teenager, young woman, coincided with that very stressful time. And I remember how health campaigns, for example, were speaking at me as a young person, but also as a Black woman, about my own body, about, of course, HIV being a disease itself, but also about my sexuality and my ability to have pleasurable and satisfying sexual experiences. And I saw how some of that immediately, when I was a junior in medical school, at the time you are still observing, right, in clinical practice, you're still observing your senior consultants and senior medical students in ward rounds. But even then already, just through observation, I could see how disempowering the practice of medicine was to patients. And this is really not because I didn't have great, teachers. Some of them are world-renowned, and to this day, I still look up to them. And they've had really quite a big impact on how I look at medicine as activism. But wherever you go around the world, medicine is still very much paternalistic, it's still very much hierarchical, and it's still very much also patriarchal. And so that also came through, right, in the way that doctors relate to their patients. So the issue of power dynamics and the asymmetry in the consultation room became something quite obvious to me. And I started to have these questions as a future doctor myself, but also as a young person who needed services of doctors and nurses, who needed dignified care, who absolutely was finding the system shaming me just for being young and Black and a woman and, potentially having sex, and what that meant for my own ability to make informed decisions, to get information, and to also access care. And so that's kind of how my activism started, very much aware also of the constraints of where I was. I had to finish medical school, I had to pass. I couldn't piss everyone off with my activism and all these radical ideas and the revolution, but I knew though to find allies within the system. And I remember particularly Professor Catherine Burns, who taught us medical anthropology early on in my life, being someone who was very affirming and who was not gaslighting us, because I think, growing up in apartheid South Africa, the system which basically legalized racism, was literally gaslighting you at every single point in your life. So even when you felt things were wrong, you were always blamed for systemic or structural, failures and issues as a person. And she was like one of the first people to actually say what you are feeling, and this discomfort and what you feel that the system is doing to you as a young person in this country is valid, and you are not, just making things up, or you are not being unreasonable. And so I started then on, making and dedicating myself to ensuring that not only do I improve the way in which doctors and healthcare workers more broadly understand human rights, because I then started to read up a little bit more about key principles in human rights, such as, dignity, equality, non-discrimination, and started to think about how does that come alive in my work every day, especially because I live in a country still where racism was something that was legalized, that permeated every single part of society. So to undo that system, to move closer to justice and equity, I had to show up every single day in a particular way as a healthcare provider, because I understood how even the healthcare system, the provision of health, the provision of underlying determinants of health, like sanitation, water, safe housing and food security, were also determined, right, in this country by racial hierarchy, and how that also compounds other inequalities such as gender, such as class, such as issue of migration, and also internal migration being important for South Africa, as we are very mobile as a community of people within the country. But what that also meant for fellow Africans who may have been undocumented in this country as they try to get access to services. And so my activism is really primarily, initially, was for my own survival as a young person who needed to survive this country. And it then, as a medical doctor, qualified understanding different ways in which I carry power in the communities where I worked as a medical intern, and also later on as a medical officer. I understood that I had so much potential to change the individual lives that I came into contact with every day. So I started to think about my consultation room as a space for advocacy, as those 10, 15 minutes with the patient where I could affirm their rights, where I could promote their access to comprehensive and dignified services. And of course, then by default, one starts, interacting with health administrators, politicians, elected leaders, policymakers, and starting to understand how public health systems are failing, but also where they work and where there are potential for collaboration, so we can scale up best practice. And that's really been my journey, very different from the traditional specialty in medicine. And it took me a while to, for people to kind of understand what it means to be a doctor, but also to be an activist at the same time. And, it took a lot of work, of convincing of even my own colleagues why we need to think of medicine as a tool for advocacy, and why medicine is itself is a defense of human rights. But here we are today, and along the way, I have met, of course, incredible scholars. I've drawn from scholarship of incredible people like Professor Kimberly Crenshaw, Professor Loretta Ross. I've, of course, like many of you, learned about people like Henrietta Lacks, who isn't even, considered, right, as someone who is an expert who actually infused and has given to the modern biomedical science. She's still spoken of as this victim, and of course, many institutions involved, in taking her cervical cells without permission to use, right, and in fact, even publishing her genome online for her cells. Have never apologized. There's never been really commitment to reparative justice and what that would look like for her and her family and her descendants. But in any case, all of these different scholars, these different people, experiences, the history of medicine has made me who I am today. And I think the fact that I grew up in an apartheid South Africa, experienced what democracy looks like, that's what gives me the fire, the fuel to keep going, because I know that in adversities we can overcome. And maybe to a fault that I'm overly optimistic, and I'm always willing to roll up my sleeves and get things done, even when the odds seems stacked up against me and those whose work benefit. But primarily, I think what I wanted to share with you today is that my framing of my work as a mandate holder on the right to health, and the very long, of course, name of the mandate being, the right to everyone to the highest attainable standard of physical mental health, is very important that you understand that history of who I am, so that it makes sense why my approach to bringing equality and democratization and decolonization to the global health space is important, why I use and reference the different ways in which slavery, colonialism, apartheid, and neocolonialism threaten the right to health. It's important for me because this is my lived experience first and foremost, but this is the lived experience of the people from whom I come. And this is a lived experience that I think is yet to find expression in international human rights in the ways that I think it should. And so through the right to health, I aim to bring that perspective that shows why it's important to understand how we have come to a place of such gross inequality in the world, and how particular health outcomes are not just a mere genetic predisposition, but there are literally systems every day that people have to navigate, that have to survive, that lead to particular outcomes for particular groups of people. And so I also focus on people with historic or current marginalization in the work that I do. I aim to be intentional in how I bring those stories, those lived experiences, and those expertise and recenter. Because I think that in order for freedom, for all of us to feel free, we have to know that our rights are respected, are promoted, and are fulfilled. We need to live in societies and governments and countries where we know there's accountability, and that requires transparency to happen. And so COVID being the context in which I was appointed the Special Rapporteur on the right to health, it became then important for me to start analyzing the impact of COVID-19 on the right to health broadly, but specifically on sexual and reproductive health. Understanding, of course, how historically the control of fertility, reproduction, sexuality, sexual health often has its roots and remnants in colonialism and slavery, and currently we're grappling with neocolonial tendencies in global health that seek and still keep certain particular people and demographics on the margins of society. So I been, of course, a sexual health educator. I've been providing services in sexual and reproductive health for many years, and I have dealt with many people with various different intersecting issues around disability, for example, drug use, for example, adolescent health, reproductive cancers, some of which we don't speak enough about, but also, of course, issues of climate change and how that impacts particular communities, not only in the fact that they are forced to be mobile and leave their communities because of either flooding or fire or drought, but also what that means in terms of them being able to access services and goods. And so I also pay particular attention to Indigenous people and Indigenous communities, because we know historically they are always kept out of services and goods, and their rights are often not protected, and there are no consequences, and there's no accountability when things go wrong, similar to people of African descent and Black people globally, where even if they live in developed or so-called richer countries, their health outcomes are just the same. For example, for Black women in maternal mortality, whether they're in a third world country or in a rich country. And it's important to get granular in the discussions. And that's where I found some of the biggest discomfort comes from, in the last, I think it's now a year and a couple of months being an SR. So I look forward to, of course, this conversation, and I know Caitlin and Benjamin will, gently, usher us and navigate us through some of these interesting, complex, but sometimes uncomfortable discussions. Thank you.
Thank you so much, Dr. T, for sharing your truth with our students who find so much inspiration in it. In these difficult times, you've laid out how historical and systemic injustices have undermined the human rights struggles that we've built over the past decades, forcing us to confront the realities of continuing patriarchy, racism, and coloniality in global health. And your work provides us an intersectional framework for redressing these threats to health and human rights. And so thank you to those who are joining us at UNC and around the world in speaking with Dr. Tlaleng Mofokeng about the impact of COVID-19 on sexual and reproductive health and rights. And as we begin our discussion, I hope to begin where you left off, Dr. T, speaking about SRHR in this moment and thinking about why we should be focusing now more than ever on sexual and reproductive health. And so I hope to begin by asking how have national pandemic responses undermined sexual and reproductive health conditions, services, information, including around sexual and reproductive health care and underlying determinants of sexual and reproductive health?
So, Ben, what COVID did was really compound in an already unequal society. And this inequality was impacting different populations differently and was causing marginalization very differently. And what happened with the COVID response, right? It was supposed to be a public health response to a biomedical issue. But in many countries, we started to see very authoritarian regimes. We started to see policy changes that were eroding previous gains made on sexual and reproductive health rights, on gender equality, or freedom of movement. And at the time, as a public health expert, I know that we needed particular behavior changes, social changes in how we interacted with each other. So the lockdowns, for example, made sense. You know, the public health information around washing hands, and eventually we were told we need to start wearing masks, and when we adhered to that, they were all important, right, to stop the spread of a biomedical virus. But in some instances, the police and the military were used to enforce lockdown regulations in particular contexts where public health information was actually dragging behind and lagging behind, and where a lot of people still didn't quite understand what is this COVID, what is this virus, and a lot of the public health information was still produced in very dominant languages, which a lot of people, indigenous, did not understand. So even in a country like South Africa that has all of its advancements and access and all of the interpretations that could possibly be utilized, did not get utilized. So a lot of public health information was in English, and a lot can be lost in translation. And so you found that citizens were being punished for breaking particular lockdown regulations. Some people were having to deal with a threat of violence from police in terms of police brutality. And many young people, if you can think, if you are an 18-year-old who needs an abortion, or you need to confirm a pregnancy to make a decision about the pregnancy outcome, to then out yourself to a police officer or to a military officer to say, well, I'm actually breaking lockdown regulation because I need to get timelier care, because we know in many countries around the world, there is a limit, right, in terms of when you can access safe abortion. Many of them have moved, even before COVID, to become more regressive and actually make access more constrained, and in some instances criminalized. So it meant that those people had to risk all of that first before they could even get to a healthcare facility. What happened though, in terms of the facilities themselves and the health system itself, many of them shifted resources in terms of funding and money, but also human resources, from family planning clinics, from adolescent health clinics, from the LGBTIQ friendly clinics to COVID related care. And that exposed underlying inadequacies of the system to cater for everyone. that even despite the national health plans, the disaster health and management plans, and the finances that were mobilized by different countries, they still failed at the time when COVID and the public health crisis demanded that. Policy failed, financing and resourcing of health systems failed, and the human rights element failed because we were not able to ensure continuity of care. In many countries around the world, people can still today not wash their hands for 20 seconds because there is just no access to water, just even for their own daily living. So those are the types of ways that COVID has impacted the right to health and some of the underlying determinants of health, and how it has impacted literal access to services for particular people.
And so as we think about these challenges for the right to health, and specifically for sexual and reproductive health and rights, how can human rights provide us with a path forward? And in thinking about that question, let me now turn it over to Caitlin Williams, who's going to help us think through what sexual and reproductive health and rights can mean as a movement for re-engaging with human rights in public health in these pandemic times. Caitlin?
Thank you for that, Professor Meyer. One of the things that's been really on my mind lately, Dr. T, is that even before COVID-19, there was tremendous concern among the sexual and reproductive health rights and justice community that sexual and reproductive health and rights would be passed over, that it would be overlooked, neglected, left behind as we started to shift into things like universal health coverage. There was this concern that it felt like the global health community was starting to move on, right? And I think with COVID-19, in many ways, we've seen that somewhat accelerate. And as brought up in your report, the stakes are actually much more dire, right? That we've seen the pandemic used as an excuse to roll back access to health, to roll back sexual and reproductive rights, as you've talked about. And so in this moment, as individuals and as a movement, a community of people who care about and champion sexual and reproductive health and rights and justice, how do we regroup and start to build an agenda that's forward-looking? If we were to try to refocus our energy, where would you suggest that we start?
Yeah, look, Caitlin, it's very hard. And one thing that has been very clear in this time is how governments, pharmaceutical companies, different businesses alike in the chain of production of vaccines, for example, have been secretive and actively keeping information away from civil society. And it becomes very hard for civil society to fight for rights, to defend for rights, to demand for accountability when they actually don't have the right information. And if you remember with the HIV crisis a few years, well, at least now a decade ago, it was civil society. It was the power of civil society. It was the organization of civil society and the advocacy of civil society that actually turned that around. And I think first and foremost, civil society advocates across the world have to demand a seat at the table at every single level of decision making in their governments as well as internationally. Because when there is no transparency, there will definitely be no accountability. And right now, we are already dealing with the crisis of COVID-19. We are already dealing with health rights abuses, some potential, some ongoing. And like you say, some of them are historical and they are still ongoing even in this time. And I think one thing we need to do is to demand substantive equality and resist to be broken up into little thematic zones or silos as people who are working in SRHR, because that further fragments the system, right? And one of the ways that this has been done is through the way in which global financing is being done, especially around SRHR, around adolescent health, around HIV management, where before you get particular grants, particular financial aid, you are meant to sign an anti-sex worker pledge, an anti-abortion pledge. That is what is also fragmenting the advocacy efforts of all of us. And we have to be intersectional in the ways that we think of the movement. And I hate to use this phrase, but it's that old UN phrase, leave no one behind. I make this argument all the time that we are already leaving people behind. It's not a thing of the future for us to not do. We are already doing it. And so in order to build back better, we need to start thinking, what was there before? Who was it working for? And if we want to rebuild that, who are we building better for? And I think those are the difficult questions that we need to ask. Do we want to build back what we had? Or do we need to start thinking completely different about who is supposed to be benefiting from social security, from underlying determinants of health, right? If you think of young women who are doing amazing work, even at this time, demanding menstrual health products, demanding treatment as adolescents with dignity in public health spaces. Many of those need support in terms of water and sanitation. How are we able to link the movement, right, for the pink tax to be dropped to other broader socioeconomic issues around having more young women in employment, for example? I'll give you another example that I think is very important for us to think about as we move forward. Do we think enough about the connections between employment equity and the human resourcing policy in the workplace and the health determinants and health outcomes? The WHO has a fantastic initiative to end and eradicate cervical cancer. But the problem right now is that because of how workplace policies are around leave, many women who need screening, who need diagnostics, who need to go back for multiple visits to a clinic for a diagnosis and a treatment plan in terms of oncology and radiation and chemotherapy and recovery afterwards. Many of those women are already living in low-income countries or situations. They themselves are using their own leave to take care of their families or extended families or their children. They cannot, because of the low-paying jobs and low labor protections, they cannot then take that time off for themselves. And that's why then these issues become not only a health or a right to health issue around eradication of cervical cancer, but it's a real discussion about workplace fairness and equity and the issues of leave and medical leave and insurance. And that's why we have to make sure that we demand that with universal healthcare coverage, SRHR cannot be left behind, because for many of those outcomes, it depends on other systems working properly. And many of them are not directly linked to the health provision, but for example, like I've just said, to the employment and the type of labor systems that we are running.
I so appreciate you framing that in that way, Dr. T, and it brings me back to your invocation of Professor Crenshaw, Professor Ross, of Ms. Lax at the beginning of this, and the ways in which intersectionality is really framing some of your analysis here, right? To say that not intersectionality in the way that we sometimes understand it as intersecting identities, but intersectionality really as understanding intersecting structures and intersecting systems of oppression, right? Which is starting to reshape some of the ways that we think about SRHR. One of the other kind of new ideas I think that you're bringing into this space and really using to revitalize the way that we think about SRHR and the right to health more generally is the role that autonomy plays. I think with my SRHR hat on, I tend to think of this as bodily autonomy, but I think that you have this really expansive view of autonomy and the way that you're approaching the right to health. And I'm wondering if you can talk a little bit about how this autonomy lens that you're bringing can help us to reframe the way that we think about SRHR moving forward.
It was important because as you, many of you know, you have to be strategic and you have to be constantly be ahead, right, of people who are anti-rights, anti-women, anti-gender, anti-everything that we are about. And one of the ways I started to talk about the work that I do is as someone who is a protector or a defender of autonomy. A lot of what has happened even now during COVID-19 is that a lot of people who are anti-vaccination have started to use our feminist language in explaining why they don't want the vaccine, right? So that my body, my choice slogan that many of us grew up with and we have such deep connections to, they've started to use that in ways that are anti-human rights, that were never designed, right, to be used. And so as a way for me to try and think afresh for myself, reinvigorate my own activism, I find that I constantly have to think of new ways of bringing people on to the cause and supporting the movement, but also within the movement, how do we keep evolving and keep moving forward, right? Because we have a lot of gains we have made, but we still have somewhere else to go. So how do we prepare ourselves? What are the tools that we need to get there? And that's why I focus also then on the restoration of dignity, because to restore someone's dignity, you need to be invested in their humanity. You have to see them as equally human. And many of the global health systems, many of the structures that we are still grappling with are very dehumanizing. And so that's why I chose that focus, and autonomy is a big element of that, because the ability to make decisions independently as to self-determine is one of the most basic of human experiences. And for me, that's where freedom lies. Freedom lies in that ability to self-determine, to do so without violence or the threat of violence or coercion or fear. And this then can be replicated in any discussion you are talking about, whether you are talking about harm reduction with people who use drugs and how that intersects, for example, with reproductive health and women who are now criminalized and incarcerated and giving birth chained to beds, right? You can see how the restoration of dignity is important in that particular instance. If we're talking about autonomy and you're talking about sex workers and how COVID-19 has impacted their ability to work physically, and how historically the stigma around sex work and sex workers has meant that they've only just been seen as vectors of disease, which is false. And now with COVID-19, those very types of messaging have resurfaced, and how then we need to change the discourse around public health, that sex workers or public health, for example, doesn't need protection from sex workers. In fact, what we need is to have, again, restoration of dignity. And for people who are in sex work, what does that look like? So it demands us to actually have the people who we claim to do this work on behalf on the table, because you can't define for me what dignity looks like. You can't define for me what self-determination and autonomy feels like in a particular moment. And so I'm trying to do a lot of things at the same time. Try and live out this very call I'm making to the global community to say, the people who are most marginalized should be recentered, but that means they should be participating. And so with the reports I do, there's a call out for contribution, and there will be the next one that I'm working on for violence for the Human Rights Council next year, where I'm saying, I need the voices of the people who are living these difficulties every single day. You tell me how your right to health violations and abuses mean for you every single day. Bring that lived experience through, because it is important. It's not just about academic excellence. People who are living every single day in these marginalized situations are having to navigate this, and it requires an incredible amount of resilience and skill and community work and organization to be able to survive many of these situations. And so to restore dignity, to affirm and protect and defend autonomy, requires us to be in conversation, but it requires to humanize one another and see each other as equal participants in this process.
In thinking about this evolving notion of dignity and reflecting on the complexity of the freedoms and entitlements that underlie SRHR, you recognize the compounding threats across multiple axes of determination, of marginalization. You state in your report that persons already marginalized in society are often left out and experience the worst harms. And you focus on a need for an intersectionality framework to redress these compounding marginalizations. How can the right to health be reframed? How can it respond to these intersectional forms of discrimination and inequality and recognize the complexity of the individual, the compounding marginalizations, and the ways in which underlying determinants of health need to be considered holistically?
It is very important. And intersectionality is not an Olympic for oppression. It's not about who's most oppressed, but it's about understanding where power lies and how power moves through you every day. And therefore, for example, I'm a medical doctor. There's a particular risks that I can take that someone else who grew up in this very community where I am today, logging in from, cannot take those particular risks just because they don't have the particular social protections, the class protections that I particularly have. And so my ability to be able to say particular things, do particular work is very important because I understand my responsibility to my community. And what binds us is not trauma or poverty or anything like that. It's humanity. It's the fact that they see me and I see them. And that's what it's really mainly about. The reason why we have to be intersectional is that if we have to think about getting to equality, equity, we have to understand that all individuals and groups should be able to enjoy equal access to the same range, quality, and standard of sexual and reproductive health services, information, goods, and services, and exercise those rights without experiencing any discrimination. Now, to get to non-discrimination, we have to have substantive equality as well. So I see intersectionality and intersectional frameworks as that bridge that will get us to substantive equality. It's not the end, it's a tool that we use to cross the bridge to the other side. And so we need to then understand the specific health needs, but also the specific barriers faced by particular people. So, for example, we understand and know very well the difficulties experienced by people who want to terminate a pregnancy. Intersectionality requires us to think further than that and say, what does it mean for the same person in the demographic who is now disabled, who is perhaps a transgender person? What does that mean for them in their experience of trying to access services when they experience these multiple layers? This person's social standing and social positioning is very different. And so how we think about solutions will require us to not just think about difference just because we are all different, but think about how systems are created to either then perpetuate that difference and discriminate using that difference to then lead to differential access or treatment provided. And so for me, intersectionality is a bridge. It's almost that compass. You know, when you are lost and you think, who am I leaving behind? What am I missing here? For me, intersectionality is that compass to think about all of the different multiple layers. And those layers affords me an opportunity to truly stand and say, in this particular work, we are going to be non-discriminatory and we are going through the different efforts we are making through scholarship, legal work. I do a lot of MKI applications and third-party interventions in many courts, including the US court, Supreme Court, through the research that we do, through these reports that I'm doing through the UN. It's important to then say, truly, we are advancing equality and non-discrimination. So for me, intersectionality is the lens, it's the compass, it's the bridge that, and it keeps growing because the intersections are also multiple. And you may experience one form now, and in a few years, you've moved and you're experiencing another type of discrimination. Yeah.
In thinking about these compounding discriminations and the structural inequalities that limit universal humanity and also limit substantive equality, you focus on the ways in which coloniality, patriarchy, limit sexual and reproductive health and rights, especially for women and girls, and the ways in which reproduction can serve patriarchal, racial, or colonial ends. how can the decolonization of global health reframe human rights, and how can human rights advocacy support efforts to decolonize global health?
That's an important one, because I don't know if we all understand what decolonization actually means, just as a community, because you see people say decolonization, but go on to mimic those very hierarchies and power dynamics that were created and effected and made efficient by colonialism, right? So it's very important for us to have scholarship and have continued discussions to thresh out what does it actually mean to decolonize global health. But one of the ways for me, I can, and I make this example very intentionally, right? It's a way that colonialism demonizes, for example, indigenous people, but it also it demonizes and belittles and erases knowledge production systems of indigenous people, right? There's a particular violence that it does to alienate and demonize indigenous traditional health systems, for example. So if we start to think about decolonizing global health, my one question I always ask everyone is, so what do you think about indigenous African health systems? Where do you place that on your agenda? Because part of what colonialism did was erase, belittle, demonize, right? Very key instruments for indigenous populations. So when you're thinking about decolonization of global health, do you still see indigenous people and their knowledge systems as inferior, as something that only belongs in those particular countries down there in local spaces? Or do you see them as equal participants, as setting the agenda on the global stage? And that usually for me is the gauge to see how far people have engaged with this idea of decolonization in the global health. But it's also important to talk about the healthcare funding and financing. And this is something that has been in all of my reports, because we know that colonialism and capitalism is what funds a lot of these ideas. So if we are going to have global health funded and financed in particular ways that still perpetuates those hierarchies, that still enables those colonial hierarchies, are we really committed to the decolonization agenda? And you see it more clearly now with COVID-19 pandemic and the vaccines, the inequity, right? What is happening is classic colonial tendencies, where those called in the global south, which are mostly previously colonized, are only seen good enough as recipients of donors, of vaccines that are nearing expiration, when they are hoarding millions and millions of doses, right? It may take Africa another 3 years before half of us are immunized. And they're the same people who are telling us that we don't want vaccines, right? So it tells you there's a lot more work that we need to do, all of us, Ben, before we can even, I think, declare any real understanding of what decolonization in global health really means, especially when we see it happening now in real time, where there's no accountability whatsoever for the horrendous vaccine inequity that's continuing, a moral failure, a human rights failure, in fact, and there's still no accountability. So we are far away, I think, from realizing that, but we have to start that conversation, but we have to be clear who we mean by that and who is at the table.
And what can we do about that? I think that's what's bringing a lot of people to the table now in these really, really challenging times with global inequity on the rise of the vaccine movement. How can we engage as faculty and students? And so let me turn it back to Caitlin to finish off our portion of the questions, and then we'll turn to students in thinking about these questions.
Now, Dr. T, one of the things that that I've been thinking about in listening to you speak, and I think that this may resonate for other students, is, you know, the challenges before us, the magnitude of the challenges before us is staggering. This can feel completely overwhelming, I think for anyone. But I think particularly as students, there can be a tendency to feel like, you know, we can't get engaged in being part of the solution until we graduate, have a degree and a title and a decade of work experience, are in a position like you are as the special rapporteur on the right to health, right? But what are the ways in which we might be able to get involved now in this moment, recognizing that the stakes are so high? What are the ways in which we can start to contribute and get involved in trying to build back better, build this brighter, more just future that really celebrates and uplifts the dignity of all people, given wherever we are, as students kind of on our journey, or as other people interested in advancing this work?
Yeah, Caitlin, this is it's an important one, but it's often a difficult one. I live by the philosophy that I cannot demand from the world which I cannot give. So if I want a just world, if I want equality, if I want all of the things that we want, I need to be able to do that and live that every day. And some of us are able to do that much more than other people. And I think sometimes and I like that example that you made, as a young medical student, I knew I was in a system that was not really designed for this type of thinking that I had. And so I had to, at some point, forgive myself for being in that system and allowing that system to do things to me that I knew were not ideal. And sometimes that's what it's about. It's about recognizing where you are right now. You know where you could be, where you should be, but that you too may be experiencing and completely be suffocated by this very system that you are trying to change. And that the system wins the minute you make the failures individual failures, right? And that's why I hate this pull yourself up by the bootstraps. When I don't even have boots to start off with, how do I start to pull bootstraps up? Let's just start there, right? So sometimes it's about that. It's about then finding ways where you can amplify other people's work that they do if you can't take those particular risks. And I say this because this work of being a human rights defender is risky. And so it's not just about get up and just go and march. People put their bodies on the line every single day, and it's not easy fighting a system head on. And so don't feel bad that you are not in a position yet to be able to be an activist or be as vocal as you need to be. Safety and security remains one of the biggest concerns for many of us. The other thing is that you are no use to the system when you're completely depleted and exhausted. So it is good sometimes to take time out. And that's why earlier on I said we need to work with each other and not in silos, because I can't be in every single conference there is on SRHR just to make sure that the issue of safe abortion is on the table. I need to know that I have allies. I have people who understand the issues, who understand the cross-cutting issues, who understand how these issues are intersecting on a daily basis. Because if I need to now try and be every single place where I think abortion is important to be raised, it's not going to be possible. I do think that a lot of our training, and I'm talking to the converted because you guys are legal scholars, but in other spaces, I think there's a lack of human rights training in a lot of the degrees. So people graduate not really understanding the harmful ways in which particular industries are operating in the world. And it's almost like this battle, right? Now you are fighting your peers head on particular issues. And it's only when they get that aha moment that they realize. So I think political education is very important. Human rights is very important. But honestly, Caitlin, start where you can, start where you are, and start with what you can. But where the opportunities arise to amplify and to support other movements, do it. Cross movement building, I think, is key for all of us, especially who are working in gender and SRHR. We cannot allow ourselves to be fragmented into little pieces. We have to demand working together, and we must be the ones who are setting the agenda. We must be the ones setting the targets, the indicators, because those indicators are qualitative, mostly are quantitative. No one is researching and tracking quality. We need to start getting back there. Quality matters, because that's the stuff of dignity, and that's the tangible stuff for communities every single day.
Thank
And
you so
so-
much for that sage advice, Dr. T, and for helping us to think forward about how we use the mechanisms of this wherever we, the human rights system, wherever we are. I'm going to hand things back over to Professor Meyer to take our last couple of audience questions and to wrap us up.
And I think as we think about the questions from students, and I appreciate your concern for the resiliency of these challenging moments and helping them to understand where they can make their mark. In thinking about these cross-cutting movements, a lot of the questions from students are really focusing on how to incorporate sexual and reproductive rights work in the larger movements that are taking place around environmental justice and climate justice, around racial justice, around decolonizing human rights and global health, around disability rights. How do we make sure that in these varied areas that have holistic impact on the health and human rights of the most marginalized, that sexual and reproductive rights are not lost?
Yeah. It's a lot, right? Because it's speaking to so many different industries, so many crises and world health problems right now. But I think also it's important, again, that question in itself, it's showing the different ways we are all linked. The question itself is showing the different intersections that we all find ourselves. And I think it's important to realize that sometimes it's about taking time to understand and for you to unlearn certain harms. Because just because you want to work in human rights, you want to end racism, sexism, inequality, you want safe abortion, doesn't automatically mean that you grew up in a society that raised you, right, and fortified you in the right ways of thinking. And I've experienced a lot of harm from my own counterparts who come into this work to save me from myself, and that's very horrible in framing and thinking. So I think one of the ways, Ben, I would say read up Black women scholars. I spoke briefly a little bit about Professor Crenshaw. I spoke about Professor Loretta Ross. Read about the women, in African American women who did a lot of work in terms of the reproductive justice movement, right? And I think bringing those women into your scholarship does a lot in removing erasure, right? The erasure of scholarship by Indigenous women, for example, when it comes to issues of climate change, very important. Wangari Maathai, an amazing African scholar, environmentalist, the stuff that is now making itself into global agendas. She's been preaching that stuff for decades, right? Read up on her work, reference her in your scholarship. And I think that goes a long way when we talk about the decolonial approach and decolonial movements that you are trying to build. And I think those are the small ways that I have really big impact as scholars when you are still limited in how far you can go. And I think, just beyond the goal of health equity, I think for me, really what I want to say today, we need a different approach. And let's let human rights be what binds us together. Culture, religion, politics, all of these things always will exist. They bring color to life, but they can't exist at the expense of human rights. And I think if you remember that, I think we will be, we will be on a good course. Yeah, but be willing to learn and unlearn certain harmful ideas and harmful norms.
Well, thank you for this amazing learning opportunity. I think it's the students, it's the next generation that gives me a great deal of hope for human rights in these uncertain times. And as we begin to draw from the references in your own report and the ways in which we can expand the conversation around health and human rights, I'm delighted that you were able to be a part of our UNC Health and Human Rights lecture. And I hope that everyone online will join me in sharing their appreciation for Dr. T's inspiring advocacy, in her mandate, her inspiring work over the past hour to share with us what sexual and reproductive health and rights means for the right to health and for the future of global health. Thank you to Caitlin for joining me as part of this conversation. And I hope that we can work together in this fight for human rights, learning from each other and building a brighter world following this pandemic and in the decades to come. Thank you so much for joining us today, and I hope that you will continue the conversation online and throughout your careers. Thank you.